Well, I'd like to thank Wendy and her incredible team for inviting me to speak. She said I was going to be the last roundup and assured me that the house would be packed, and it is, and thank you all for staying. You know, I'm actually a neuro-ophthalmologist by training, and I've been here for the past couple of days listening to phenomenal speakers and have learned a lot, even though, you know, this isn't what I do every day. I'm kind of removed from ovaries and breasts and uteruses and voiding and things like that. But it has been fabulous. I've learned a lot. Well, I've learned a lot about myself. I've learned that I thought I was short, but now I know I'm intrapenic. And I learned that I really don't have osteopenia. I'm just short and normal, and took alendronate for a long time for no reason. I think it's important for every speaker to like teach you a new word, so mine's going to be trichopenia. I don't have too much hair either, but what I do have a lot of is enthusiasm for headache medicine and for teaching about headaches and treating people with headaches, and let's rock and roll. So it's not really as good as it looks, but I do have a few disclosures. They haven't made me rich. I guess all of us have gotten up here and made the case about how our disease is the worst disease, right? And in fact, migraine is really common. So the average lifetime percent of the population that gets migraine, 22% of women and 10% of men. And over the lifespan, I'll show you the graph later, women are 3 times more likely to have migraine than men are. And hormonally associated migraine affects 12 million women in the United States. Let me also add that in the slide deck that's available online, there are actually more slides than I'm going to show today, so there'll be a little bit more detail. Is it really migraine? So there are official diagnostic criteria for making the diagnosis of migraine. The most common type of migraine, which used to be called common migraine, is now called migraine without aura. So this affects probably 70 to 75% of people who have migraine. And the International Headache Society criteria require that you have at least 5 attacks. So it's kind of like high blood pressure. You don't make the diagnosis with one abnormal reading, but you have to have numerous attacks in order to actually make an official diagnosis of migraine. The headache in adults, either untreated or unsuccessfully treated, should last between 4 and 72 hours. Now in children, the headaches tend to be much shorter, and so the official criteria in children allow for only an hour. At least to the following: one-sided, that's how migraine got its name, but it doesn't have to be one-sided. Pulsating or throbbing in quality, moderate to severe in intensity, which it usually is, and then the one that really helps me when I'm taking the history from the patient is that it's aggravated by routine physical activity. So walking around, going up and down stairs. People with migraine, they want to be, you know, down and out in a dark room. And then during the headache, again, the criteria require at least one of the following: nausea with or without vomiting, and sensitivity to light and sensitivity to noise. Now, people are often sensitive to other things as well, commonly odors. Some people are sensitive to touch, but they're not really required for an official diagnosis. Migraine with aura is a little easier because the aura is usually a giveaway. And you'll see the picture up there of the most classic type of aura, which is called the scintillating scotoma. So most people who have aura will have visual aura, although there are other types which we'll talk about. So generally it starts with, you know, some little thing off in the corner that's just not quite right, usually shimmers a little bit. Sometimes it's in color, sometimes it's silver and black. And then over time it gradually gets bigger, it shimmers some more, and then there's this big area around the outside that's the scintillation or the shimmering. And then there's an area within that that you can't see through well, and that's called the scotoma. And the area gets bigger, it moves across the visual field over anywhere between about 5 and 30 minutes, and then it breaks up. And then most people will have a period of time between the aura and the headache itself. So to have a diagnosis of migraine with aura, you only need 2 attacks, and then you need to have fully reversible neurologic symptoms, which may be visual or otherwise. They may occur in succession. And so people who get more than one aura symptom will often describe a progression from one thing to another to another. First I got the visual symptoms, then I started to have some tingling. It sort of marched up my arm, it went to my face, it crossed over to the other side, which is always a nice thing to hear because it means it's not a stroke, right? Went to the other side, and then I just couldn't get the words out, and I couldn't think straight, and then, ultimately the headache comes on. Besides visual disturbances, sensory disturbances are also pretty common. Again, it's usually tingling, but some people will actually describe true numbness, like can't feel it numbness. Unlike vascular disease, the numbness of migraine may affect the tongue. So when you hear about people that have strokes and TIAs, they don't get tongue numbness, but that can happen with migraine, and it'll help you. Motor weakness can occur. It puts us in a different category of migraine, and when we go to treat it, it kind of is a little bit distinct. But people can certainly have weakness. The weakness often comes on again gradually, as opposed to the sudden onset of weakness that people get when they're having a TIA or a stroke. Occasionally we'll hear about people who have olfactory sensations, similar to those that occur in epilepsy, smelling a bad smell beforehand. Vertigo and dizziness can also occur. On the bottom is a picture of what's called the fortification spectra, which is another pretty common visual manifestation of aura. It's named because it looks like an aerial view of a medieval fortress. On the top of the picture, again, another pretty common visual aura is kind of a C-shaped, shimmering, scintillating figure that appears out in the peripheral vision. Speech may be dysarthric, so it is difficult to understand, although the content is normal. Or some people will actually develop true aphasia. I've never seen anybody, or even heard of anybody, with Portuguese aphasia, where they just start having gibberish and they can't understand anything. But most people just have what we would call a Broca's aphasia or motor aphasia, where they know what they want to say, but they can't get the words out right. Behavioral things can also occur as part of the migraine aura. Out-of-body experience, autonomic behavior, emotional changes. We'll talk about the prodrome in a few minutes, but a feeling of anxiety, a feeling of euphoria, déjà vu, jamais vu. Brainstem type symptoms can also occur, seeing double, droopy eyelid, altered level of consciousness, sometimes frankly passing out can occur as part of the migraine aura, imbalance, a dilated pupil on one side, which sometimes happens in the absence of the headache. Hearing sounds or usually like musical noises. What is not considered aura is blurred vision. That's very, very common with migraine. It's probably not a cortical symptom. At least I don't think so as a neuro-ophthalmologist. That's a whole other story. And then the premonitory symptoms that occur are actually considered different than aura. We'll get to those in a few minutes. Now, you don't have a million years in your office to sit around taking this whole gruesome and grueling history about the details of somebody's migraine. So there have been various scales devised in order to try to make a quick and easy diagnosis in your office. Clue number one is if somebody comes to your office when they complain about headaches, they probably have migraine, because it's the #1 cause of headache that people see the doctor for. As a headache specialist, I never see people with tension-type headaches. And my colleagues in headaches, we never see that either, even though tension-type headache is the most common kind of headache. We see people with migraine by far and away. So if people come in and they complain of headache-related disability, they have to stop what they're doing because of their headaches, they're missing work, they're missing out on life's activities. If they have sensitivity to light with their headaches and nausea, chances are, you've only had to ask 3 questions, they have migraine. If you get the history of aura, especially visual aura, you're done. It's 100% sensitive. So there are phases that people go through when they have migraine, and about 30% of people will actually describe what are called premonitory symptoms. And these can be fairly subtle, and often I have to ask people about them because they don't even realize they're happening. But anywhere up to about 24 hours prior to the onset of headache, people may experience uncontrollable yawning, an unexplained change in their mood, either way, either euphoric or depressed, like out of the clear blue sky. And it's really disappointing when people get euphoric because they have this feeling like they conquer the world, they have tons of energy, and then boom, they get a migraine. It's really not fair. Sleepy for unknown reasons, food cravings. Now, we could talk about migraine triggers. Unfortunately, I don't have time to in this talk, but what's the #1 migraine trigger that's a food? chocolate. Okay, now the bad news is that, well, yeah, chocolate can be a food craving. I mean, it can be a trigger, even though being a chocolate lover, I try to defend it at any opportunity. But, you know, if you're going to crave something, you know, you're not going to crave asparagus, right? You're going to crave chocolate. So some people crave chocolate as part of their prodrome or their premonitory symptom. They're going to get the migraine anyway because they have the premonitory symptom. And then chocolate gets unfairly blamed. I hate when that happens. Excess thirst, excess urination. Then those people that are going to get aura, again, it's a small percentage, maybe a quarter of people will get aura. And then the headache starts. And in most people, the headache starts gradually and then builds in intensity. Some people will describe a sudden onset or a thunderclap onset of their migraine. That's unusual, that can occur. The headache goes on for as long as it's going to go on, and then it gradually gets better. But even the next day, most people with migraines, they just don't feel quite right. It's called the postdrome, just not quite as snappy and sharp as they feel they should be. So there was a large study that was done about taking the history in migraine patients. And it was sort of done to simulate the primary care setting. So 12-minute visits that were conducted by either a neurologist or a primary care physician or a nurse practitioner or a PA. And the patients came in and they were all audio recorded and video recorded. And then they interviewed everybody afterwards to see, you know, what they thought about the visit. And what they found was that 91% of the questions that were asked during the interview were either short answer or closed-ended. Do you have nausea? Yes, no. No. Is it throbbing? Yes, no. That when they got through, 90% of the visits failed to address impairment in any way. And 60% of the patients that came in were severely impaired during their migraine attacks. You know, the WHO was mentioned yesterday. So I have to say, we get a 10 out of 10 in migraine. The scale goes from 0 to 1 to 10, 10 being the most disabling. And during the migraine headache, the World Health Organization says that migraine is the most disabling condition beyond blindness and right up there with hemiplegia and quadriparesis. Can you believe it? Okay, so during migraine, people make fun of it. It gets no respect. It is very disabling. Of the 50 patients that were interviewed, 35 of them were not put on a preventive after their first visit, but half of those people would have qualified for being on a preventative medicine based on standard guidelines. So then what they recommend is, again, cut to the chase, ask the important questions. How do migraines affect your daily life? How do migraines affect your work and your family? And how do you feel when you how does having migraine make you feel even when you're not having a migraine? Because there's a ton of anticipatory anxiety that goes along with this. And it really makes people totally centered around their migraine. And be ready, have the Kleenex, because when you ask that question, your patients are going to cry, because nobody's ever asked them that question before. Other general features, you know, we'll talk about the women's life cycle, but migraine does change throughout life. It changes with hormones. You can have migraine without having headaches, so it's possible to just have the aura. Kids get migraine too. People with migraine often have other kinds of headaches as well, frequent intention type headache, and it does run in the family. So this is the graph of migraine prevalence, meaning how many people at any given time have migraine. You'll see that for men who are in the green on the bottom and women up on the top, the graphs have a very similar shape. But there are two main differences. One is that the women outrank the men, right? 3 to 1, 18% of women have migraine, only 10% or 6% of men. But they peak around the same time, but they peak a lot more steeply for the women. So migraine tends to peak in the most productive years of life, but you'll also notice that on either end of the graph, for both sexes, it never goes to 0. And it does tend to get better throughout life, for women in particular at menopause, but little kids can have migraine, older people can have migraine, and the prevalence is never 0. So we like to talk about the estrogen paradox of migraine, and you know, I'm no GYN. You guys know a lot more about hormones probably than I do, and so I'm not going to pretend to be an expert in this field. But there is something about having estrogen that makes you more likely to have migraine. That said, migraine tends to come on in periods where estrogen is falling. So before menses, around the time of pregnancy, postpartum rather, perimenopause, and then for women who are taking oral contraceptives that have that pill-free week during the pill-free week. I'm going to just kind of start from childhood and go through it as fast as I can. Migraine in kids, it is, I think, a very underdiagnosed condition. A lot of kids get written off as having, school avoidance behavior, but it affects 6% of children. Before puberty, boys and girls have about the same prevalence. After puberty, the girls take off. I think it's interesting that the peak incidence of migraine with aura in boys is only age 5. Girls, it's age 12 or 13. And boys do tend to outgrow their migraines, so often by the time they hit late adolescence, their migraines are gone. The problem with young people, young children, is that they often are not able to articulate their symptoms well. Often the criteria have to be inferred by behaviors that are noticed by their parents or their caregivers, and their headaches are shorter than adults. There are some equivalents or accompaniments that sometimes go along with having migraine that you should look out for in kids. If you are a family practitioner, episodes of unexplained vomiting and abdominal pain lasting, an hour or more, maybe migraine in disguise, attacks of imbalance or dizziness that come on for unknown reasons lasting minutes, attacks of torticollis, vomiting or imbalance that come and go, alternating weakness on one side or the other might be a manifestation of hemiplegic migraine, and then headaches that are followed by a droopy eyelid and double vision. These are uncommon. It's ophthalmoplegic migraine, but it can be a form of migraine that most commonly occurs in children. What about menses? Menses, migraine loves change, and we'll talk about the whole hormone thing in a second, but anything that disrupts your schedule, your diet, your hydration status, your sleep pattern, migraine loves that stuff, okay? So migraine often comes on during menstruation or before menstruation because of hormonal change. And we classify it in 3 different ways, either pure menstrual migraine, which means migraine only at the time of menses, menstrual-related migraine, which means menses and other times, and then perimenstrual migraine. And I find it very helpful to ask my patients to keep a diary and keep track. So again, many of you probably know this chart a lot better than I do, but given that all those lines of various hormones are going up and down, it is like no wonder that women get migraine, right? It is a total roller coaster, and migraine loves this. We heard about PMS and premenstrual dysphoric syndrome yesterday. Just kind of keep in mind that with all the symptoms that were mentioned yesterday, migraine is on that list. It was on the speaker's list as well. And so it's not really uncommon for migraine to keep the company of other premenstrual symptoms. As was mentioned yesterday with the depression talk, we've looked at hormones to see if there's any difference between women who have migraine associated with their menses, women who don't, and have never really found much of anything. But women who have menstrually associated migraine tend to say that their migraines are more severe during menses. They tend to be harder to treat during menses. The data doesn't necessarily bear this out, but everybody's saying it. So when enough patients come in and tell you, you got to think there's something to it. There are different ways of treating menstrual migraine. One is just treating the headache itself, so using migraine-specific medications, anti-inflammatory medications, using standard preventative treatment, and maybe just bumping up the dose a little bit if it's needed right before anticipated menses, if it's predictable. Using a short-term preventative, so-called mini prophylaxis, either starting a non-steroidal or perhaps a long-acting triptan. The 2 that were studied for this purpose were naratriptan and frovatriptan. Honestly, I don't think it really makes a difference which triptan you use. But again, if the woman's periods are regular, if the migraines are predictable, just starting something a day or 2 prior to the predicted onset of migraine is often very helpful, and then just continuing that through the cycle. Starting a little magnesium is often helpful as well. Then they get diarrhea. Come see my colleague we just heard from. Hormonal therapy may be helpful, and then again, increasing the usual preventative. Non-pharmacologic therapy, there's a whole slide on this in the slide deck about other things that you can try besides using medications. As far as oral contraceptives, I understand this was actually covered to some extent on Friday before I got here. But what we want to try to do when we use oral contraceptives in women who have migraine, should that be the treatment we want to go with, is not to mimic Mother Nature. Okay? So what we want to do is get rid of the roller coaster ride, make everything nice and flat, monophasic pill, no change, continue it, at least for 3 months at a time, and just prevent menses and prevent all that fluctuation that's triggering the migraine. And you can see that there are other options that we can have as well, using low-dose estrogen instead of the pill-free week, or contraceptive patch and vaginal ring for, again, a little more of an even hormone level. Migraine in pregnancy, this can kind of go either way. So, it's the rule of thirds, right? Get worse, get better, get the same. It can really go either way. A lot of women have worsening during their third trimester, but often migraines will get better during pregnancy, and we always hope that will happen because the treatment of migraine during pregnancy is really limited. So there are women who only have migraine when they're pregnant. I've seen lots of women who only have aura when they're pregnant. So again, anything can happen. There are a lot of bad reasons one can have headaches during pregnancy. So, just again to be brief, there are a lot of things we need to worry about when we hear about the onset of migraine or the marked worsening of headaches during pregnancy. Anywhere from increased intracranial pressure to venous sinus thrombosis, stroke, vasculitis, intracranial hemorrhage, or the last one, which is what the MRI is, which is reversible cerebrovasoconstrictive syndrome, or RCVS, which causes headache, often encephalopathy, and then focal neurologic deficits. It can occur at any time, not just during pregnancy, but it's in our differential diagnosis. So in general, things vary a lot. Pharmacokinetics change during pregnancy. The ability of the drugs to work and the absorption of the drugs changes during pregnancy. There's also a change in the ability to metabolize drugs during pregnancy. I refer you to Sylvia Lucas's very nice article about this subject that's referenced in your slide deck. What can you use? Well, not a heck of a lot, unfortunately. So non-steroidals are okay, but we want to avoid them in the third trimester because of the ductus arteriosus problem. Caffeine, it's safe to use, but like any of the other opioids that are listed on the slide, we want to just really be careful for medication overuse, not only because of the effect on the fetus, but also because of the effect on the headache. It can make the headaches worse. Steroids can be used if needed. Barbiturates, opioids, benzos, again, you really just have to be careful. They're considered category B, but we don't want to do anything that might be dangerous. Triptans are all considered category C, which means, you have to weigh the risks and the benefits. And there's certainly many, many women who have taken triptans through their pregnancy and done just fine. There's a registry that is kept by Glaxo, which is the company that originally made Imitrex. And they have a huge pregnancy registry and really have not shown any downside to using triptans, or at least their triptan during pregnancy. But the ergots, the hyperergotamine and the other ergotamines, are contraindicated because of the potential effect of vasoconstriction of the placenta. As far as treatment of nausea during pregnancy, the medications that are listed are all considered category B. So they are at least felt to be safe to be used during pregnancy. Anticholinergics, you can run a risk of meconium ileus. As far as prevention during pregnancy, this is also kind of tough. Often we can use natural things. Magnesium is really a great choice to use for prevention during pregnancy. Vitamin B2 or riboflavin is also a good choice. You can see that there are a few category B drugs up on there, a few category C drugs up on there. Again, it's just like as was mentioned with depression yesterday, it's a matter of weighing the risks and the benefits and making an informed decision with the patient. There are some drugs that you should not use during pregnancy for migraine prevention. Those include the anti-epileptics, particularly valproate because of neural tube defects, topiramate because of cleft palate, and then lithium. Breastfeeding, there's very little known about breastfeeding. There's a reference in your handout about a book that can be used, and you can look up various medications and see what will happen. Basically, is the drug safe? Do you have to use the drug? Think about passing of the drug through breast milk. There are a list for you in your handout of things you can think of. Perimenopause, again, hormones are going crazy, migraines are going crazy. Low-dose hormone replacement therapy can be considered. Low-dose oral contraceptives without the placebo week can also be considered if you want to, again, try hormonal therapy. There are a lot of standard migraine preventative medications that we can use as well. In menopause, every woman hopes that their headaches are going to get better in menopause. Most of the time they do, but unfortunately not always. Some women come to see me and ask, should I have, an oophorectomy? What's surgical menopause going to do to me? Unfortunately, it's probably not going to do anything good because that rapid change in hormones after surgical menopause often makes migraine worse. Sometimes women will develop migraine for the first time after menopause. So again, as far as hormone replacement therapy, there are really conflicting data regarding migraine. There have been no randomized controlled studies. So one size does not fit all, and you really have to analyze the risk and the benefit. Migraine and stroke is kind of a hot topic. There are a lot of data that have come available, mainly through the Women's Health Study. The risk of migraine and stroke seems to be predominantly for women who are under age 45. There was a large population study that was done in Europe that showed a lot of these asymptomatic cerebellar infarctions in patients, which really brought this to our attention. To make a long story short, the risk seems to be increased the most in women who have migraine with aura, where their risk is somewhere between 2 and 3 times their age-matched cohorts that do not have a migraine with aura. Migraine without aura does not confer any additional risk. I think that the thing that's really important about this is to kind of look at the whole picture. And so it's not just having a migraine with aura, it's also oral contraceptives, which we will talk about. It's smoking, it's family history of stroke, it's age. So again, I don't think there's a blanket of, absolutely there's an increased risk and absolutely nobody with aura should ever be on an oral contraceptive, but I think you need to look at the big picture. As far as oral contraceptives, there is an increased risk of stroke with women who have migraine and aura and oral contraceptives, controlling for major vascular risk factors. But the risk, again, varies by age. And so the risk in a 20-year-old, although it's higher than her non-migraine peers, is still pretty low. And we really worry as women start to get older because their risk, as you can see, goes up tremendously. In summary, migraine doesn't increase the risk of stroke. The things that seem to be important are the presence of aura, being female, age over 45, high frequency of migraine attacks and long duration of migraine, and using the oral contraceptive will increase that risk even more, particularly for venous sinus thrombosis. I believe this was covered in a previous talk, so I'm just going to kind of skip it. But again, women over age 35 who smoke who have migraine with aura, we certainly wouldn't want to use the pill. There's also evidence that migraine increases the risk of cardiovascular disease in women. You can see the statistics that up to twice the risk for MI in women who have migraine. This is from the Women's Health Study. Keep in mind in the Women's Health Study that the history of migraine was as reported by the women. It was not specifically asked about in any particularly any of these questionnaires or anything like that. Migraine does progress over time, and we divide people with migraine into episodic migraine, which means migraine 15 days or less out of the month, versus chronic migraine, which is more days than not. And to be a chronic migrainer, all those days don't have to be migraine. So you can have migraine several days out of the month, have other kinds of headaches, but if you have headaches more days out of the month than not, and some of them are migraine, then you get to be called chronic migraine, which is not really much of an honor. There are some things that seem to predispose to the chronification of migraine and the development of allodynia. So in a large study, they found that the things that predict progression are the overuse of medication, which is a huge problem, even over-the-counter medication, especially medication containing caffeine, those containing opiates. A lot of people like to throw these medications at patients, especially when they go to the emergency department. But in reality, when people with migraine use these medications frequently, it makes them worse. Being overweight is a risk factor for the chronification of migraine. And in fact, the patients in a very large population study that were obese, that met criteria for obesity based on BMI, their risk was 5 times that of non-obese patients as far as the development of chronic migraine. Low socioeconomic status and a history of head injury, stressful life events, and snoring, which just may be a marker of obstructive sleep apnea, are also risk factors for migraine becoming more chronic. So some of these we can modify, and some of these we can't modify. There's a concept in pain in general, and migraine in particular, called allodynia. And allodynia means that something that shouldn't be painful is painful. So during migraine, almost everybody has allodynia, sensitive to light, sensitive to noise. But with the longer the duration of migraine over the years, the more likely it is that migraine sufferers will develop allodynia at other times, not just when they have their headaches. And it usually takes many, many years for this to develop. So when we're taking the history and we're asking about allodynia, some of the questions to ask are, when you have your migraine, does it throb? It's thought to be the spinal fluid pulsations that you don't normally feel, that you can feel during migraine. Does your hair hurt? When I did my residency, that was considered a question that you asked people you thought were crazy, right? Does your hair hurt? Yeah, right. But actually, your hair can hurt when you develop allodynia. Do you have to take your eyeglasses off when you have migraine? Take your jewelry off when you have migraine? Does it hurt to touch your face or your head when you have a migraine? And then that's called peripheral sensitization. Central sensitization occurs during an attack when the patient can tell you that their pain is worse when they cough or sneeze. And the reason to ask about allodynia is that the triptans are less likely to work once that takes place. So basically, when we're trying to think about how to treat patients with migraine, we try to stratify them based on their disability. So patients who have low levels of disability may be able to get away with just symptomatic therapy or over-the-counter therapy. As the disability becomes greater, they may need triptans. They may need to start thinking about preventative therapy. And as this disability gets even higher, they need to see a headache specialist. They may need to be hospitalized. They may need to be on multiple preventative medications. And also talk about lifestyle modification. So in summary, yeah, women are different when it comes to migraine. Migraine does change throughout the reproductive cycle. Estrogen does seem to be an important factor in influencing migraine. And migraine may be a progressive disorder in some people. And so consideration of preventative treatment is very important. And I'm happy to take your questions. You're on. You're on. The question is about triptan and SSRI. So there's this famous serotonin syndrome, which the FDA has made a really big deal about because a handful of patients were reported with it. And I will tell you that we just don't see it. And there was a meta-analysis of the literature that was reported in Headache a few years ago, and I think there was a more recent analysis that was just reported. And I think it's very, very rare. We use SSRIs and antidepressants all the time in patients who have migraine. They often have comorbid depression and anxiety. And it may be one of the reasons why people say they don't, quote unquote, tolerate triptans. But to see true serotonin syndrome is extremely, extremely rare. Case overblown. Yes?
Can you comment on the use of ACE inhibitors as migraine prophylaxis?
There is some evidence. There are a couple reports in the literature of ACE inhibitors that are being used. There are actual guidelines that are published by the consortium that includes the American Academy of Neurology about prevention.